We are moving on with our embryology session. This is continuation of chapter 4. We have general embryology part 6, second week of development, bilaminar germ disc foundation module part 6. And we will cover these objectives of bilaminar disc formation and abnormal implantation. And in the end, we will discuss the retention techniques. Next, at day 13, surface defect of endometrium is completely healed. Bleeding occurs at the implantation site due to increased blood flow in the lacunar spaces. So here is the increased blood flow from maternal sinusoids to the syncytial lacunar spaces. This bleeding occurs near the 28th day of menstrual cycle, may be confused with normal menstruation, leading to inaccuracy determining the expected date of delivery. So basically in menstrual cycle, after the event of ovulation, there is either implantation or shedding of the endometrial layers, which is called menstruation. So if there is implantation and the bleeding occurs, the expected date of delivery is calculated by plus 9 months after the last menstrual cycle. So basically we get inaccuracy in determining the correct pregnancy date. In the 13th day, there is formation of primary villi, which is the projections. Villi are basically the projections. Cytotrophoblast penetrate deep into the syncytiotrophoblast, forming cellular columns. Cytotrophoblastic cellular columns with the syncytial trophoblast covering our primary villi. Here is the cytotrophoblast cell column covered by the syncytiotrophoblast. This is primary villi. Secondary yolk sac or definitive yolk sac, hypoblast cell produce additional cells that migrate inside the exocoelemic membrane. They form new cavity within exocoelemic cavity or primitive yolk sac cavity. New cavity is secondary yolk sac cavity or definitive yolk sac. Here is the exocoelemic cavity or primitive yolk sac. So the cells from the hypoblast, they basically migrate into the exocoelemic cavity or primitive yolk sac and form the secondary yolk sac. Secondary yolk sac is much smaller than the primitive yolk sac. Here you can see the size of primitive yolk sac, and secondary yolk sac is much smaller. During formation of secondary yolk sac, large portion of the primitive yolk sac or exocoelemic cavity is pinched off. So here is the pinching off of the exocoelemic cavity or the primitive yolk sac. These portions of exocoelemic cavity find in extra embryonic coelom or chorionic cavity. This is the chorionic cavity which we discussed earlier. These are called basic. Meanwhile, extra embryonic cavity expands and form large cavity, that is chorionic cavity. This one is the chorionic or extra embryonic cavity. Extra embryonic mesoderm inside the cytotrophoblast is chorionic plate. Here the invagination of the mesoderm in the cytotrophoblast is chorionic plate. Only at the point of a connecting stalk, extra embryonic mesoderm transverses the chorionic cavity. Here you can see it transverses the chorionic cavity. The blood vessels development stalk forms the umbilical cord. Here the blood vessels develop into the connecting stalk. So again, we are at the week of 2s. So we have the mnemonic great calm. For the G, we have germ layers that are for the embryoblast 2 layers. For T, we have trophoblast. For C, we have cavities. And for the M, we have extra embryonic mesoderm. Next, this one is important. At 8th day, the trophoblast divides into cytotrophoblast and syncytiotrophoblast. Embryoblast divides into epiblast, develops amniotic cavity in it, and the amnioblast are epiblasts that are surrounding amniotic cavity. At day 9, two embryonic poles occur. Embryonic pole, we have syncytiotrophoblast. At ab embryonic pole, hypoblast form thin exocoelemic membrane. Exocoelemic membrane and hypoblast lines the primitive yolk sac or exocoelomic cavity. At day 11 and 12, there is decidual reaction between primitive yolk sac and cytotrophoblast. Yolk sac gives extra embryonic mesoderm, which can be somatic, which we discussed earlier between the amnion and cytotrophoblast, and splanchnic, which is around the yolk sac, and extra cavity, that is extra embryonic cavity. At day 13, cytotrophoblast develops into primary villi. Hypoblast cells enter the primitive yolk sac and gives the secondary yolk sac with the exocoelemic cyst. Connecting stalk forms the umbilical cord, and the extra embryonic cavity expands and forms the chorionic cavity. So for the retention technique at day 8, 8 looks like B, so there are more blasts. So from trophoblast, we have cytotrophoblast and syncytiotrophoblast. And from embryoblast, we have hypoblast and epiblast gives amniotic cavity and amnioblast. At day 9, 9 looks like P. So we have poles, embryonic pole which has lacunae formation, and abembryonic pole which has primitive yolk sac from the P and from the hippoblast, that has P in the name. Next, we have day 11 and 12, and 111 looks like E and M. So we have extra embryonic mesoderm, which can divide into somatic and splanchnic, plus it gives the extra cavity or extra embryonic cavity. Next, we have day 13, and 3 looks like two C's. So we have cytotrophoblast forming primary villi, secondary yolk sac formation, exocoelomic cyst formation, connecting stalk forming cord umbilical, and expansion of the extraembryonic cavity to chorionic cavity. Next is abnormal implantation. So we have syncytial trophoblast, the outer trophoblastic layer secreting HCG. So sinful people go to High Court, HC. So abnormal implantation can be at uterus, that can be at the level of internal os. Here is the level of internal os. This is called placenta previa or low-lying placenta. Normal implantation is at this point. Next is extrauterine or ectopic pregnancy. 95% of the time it is in the uterine tube. Here is the uterine tube, and most of the time it is in the ampullary portion or ampulla. Next is the abdominal cavity, which can be in rectouterine pouch. Back of the uterus is rectouterine pouch. It is at the back of the uterus and also called the pouch of Douglas. This is called pouch of Douglas. Next, if you imagine a woman standing like this, here is the uterus, and at the back of this there is rectouterine pouch or pouch of Douglas, or this is also called cul-de-sac. Next can be peritoneum or omentum of the intestine, that is protective connecting tissue of the intestines. Next is the ovarian pregnancy, which implant is at the ovary. Normally the ovum moves here to the ampullary portion, and then it fertilizes with the sperm in the uterine tube, then it moves to the uterus for implantation. But if it is fertilized in the ovary, that is ovarian pregnancy. Next is ectopic pregnancy. So we have two in the name. So we have 2% of the ectopic pregnancies occurring. Next, we have abnormal blastocyst. If trophoblast develops placenta with little or no embryonic tissue, this can be non-cancer or cancer. Cancer is invasive mole or choriocarcinoma. Non-cancer is hyatridiform mole, which has high beta HCG. This is diploid. Mainly, it is consisted of paternal material. Oocyte fertilization does not take place. This can be 46XX or 46XY. So here, the male sperms goes and it forms two male pronucleus, and female maternal DNA is lost, and only these two combine and they form diploid cell, which can be 42XX or 42XY. This is hyatridiform mole. Next, during implantation, if trophoblast is invading material and it contains the paternal gene, it is the foreign body. Why is the conceptus not rejected? Because the humoral immunity or B cell immunity with the antibody is reduced by the pregnancy. Next, a woman who believes she is pregnant complains of edema and vaginal bleed. Examination reveals plasma HCG concentration and placental tissue, but no evidence of embryo. This can be hyatridiform mole. Question 4. A young woman who has missed 2 menstrual periods complains of intense abdominal pain. What might be initial diagnosis? This can be ectopic pregnancy. How would you confirm it? By the vaginal ultrasound.